You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand-in-hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient, family, donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
we are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP Research Services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
Nous.
Noi.
Nos.
Emis.
Nosotros.
Mink.
Kiano. We. Kiano.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.
My great pleasure to introduce our first speaker this morning, Dr. Caroline Tait, who is a medical anthropologist with particular research interests in Indigenous health and social justice. She's a member of the Métis Nation-Saskatchewan and grew up in a small Métis community in central Saskatchewan. Dr. Tait is a member of the Faculty of Social Work and the Cumming School of Medicine at the University of Calgary. Dr. Tait is also the lead of the CDTRP Indigenous platform. So now over to you, Dr. Tait.
Great. Good morning, everybody. I'm in Saskatoon this morning, and not at my home at Elkridge, a little bit up north. So we'll just go to the next slide. Yeah, so most of you probably have had some interaction with me if you work in Indigenous health at all. I'm in Treaty 6 territory this morning and my traditional homeland. So I grew up on that farm up in the corner, and these are some pictures of my family, and some of you've seen them before. And in the middle, the group picture is of our think tank that we had back a few years ago. And actually tonight in the middle, you can see with the very fancy pants is Monica Goulet, who's hosting with the Kidney Foundation tonight at Whitecap Dakota First Nations at the hotel there. They're hosting a fundraiser for the Kidney Foundation. So I'll be at that tonight, and we'll look forward to seeing some of the people from our think tank, including Dr. Mike Moser. And Ernie Sauvé, one of our elders. So just to the next slide. And I'm just really happy to be here. I've had a relationship with CDTRP for the last year or so. And I just want to give you, before I start, a really quick update. Some of you may have attended our Cafe Scientific that was held in February 2024, funded by CIHR. Grand Chief Phillips was there, who's a patient, a double transplant recipient. And out of that cafe, we just had this week, it was very exciting to be online and watch a resolution passed by the BC First Nations chiefs prioritizing organ tissue and donation and transplantation as a health issue for BC First Nations, and we hope to move that forward. And again, as a patient advocacy piece, I will be meeting with our elder Ernie Sauvé, who's one of our Cree elders. We'll be meeting with Thunderbird Partnership Foundation in July of 2024 to support the prioritization of Indigenous patients living with alcohol-related liver disease to gain access to residential treatment and other alcohol treatment and aftercare supports. And I won't go into detail about that, but it's an important piece for our people because of that being a central health issue for many communities. Next slide, please. So I'm going to start, and I told Manuel I was going to do one thing, and now I decided after yesterday to do something a little bit different because of the questions that were raised yesterday in the patient forum. So I hope that this will be this will be very provide you with some information and some context about why Indigenous people are concerned about participating in research, and particularly patients, families, persons with lived experience. But we need to go back. We always, when you're working with Indigenous people, you need to look at the history of what happened. And back in 1996, I was around, I was at McGill, I was a student, and I was living in Montreal, and the Royal Commission on Aboriginal Peoples came out, just like the TRC came out about 5-6 years ago, and we were so excited. But one of the things that the Royal Commission talked about was research, and the fact that oftentimes research has not benefited Indigenous people, and that Indigenous people do not have control in research in the ways that they should, based upon their nationhood and based upon their Indigenous rights. And out of this came the First Nations Information Governance Center. And I'll just get you to go to the next slide, please. And so right now, and I'm not going to go into detail, you can find information about these. There's training on the First Nations principles, which are ownership, control, access, and possession, OCAP. And OCAP has been around since the 1990s. I just finished working with Métis Nation, developing the Saskatchewan Métis Research and Data Principles, which I do training on, and they look a little bit different than the OCAP principles. And then you also have the National Inuit Strategy on Research. But what I want to explain, which I think is interesting for patients and families, is that Indigenous peoples, we've been doing research, lived experience research, for decades now, for over 30 years at least, if not even before that. And the reason that we do patient-oriented or lived experience research is because it is a cultural value. It is important, you know, that you hear from the voices of people and the people who are going through those experiences. So that's really good news, that we have a long history of doing the types of research that you would call now patient-oriented research, for instance. Next slide. So I want to draw attention, if you were watching the news this week, there was an article, well, it was an article, it was on the national news about the Prince Albert School study. And I thought it important at this point in time, because I've had lots of access to all the documents from the reporter. And so I've gone over all those documents. I was asked to by Jeff Leo to look at what happened in this case and where did things go wrong. I raise it here not because it's a project on organ donation and transplantation, but it's a project with Indigenous youth and children and their families. And I want to draw attention to you that this happened a decade ago, which isn't that long ago, but it's only now that we're getting the type of attention where maybe there will be some type of investigation in terms of what happened. But to tell you that this is still happening for our people, in particular for vulnerable Indigenous people. So I'm going to show you kind of more or less what happened. Some of you will know from watching the news report, but I'm going to also show you what we need to do to make sure this doesn't happen. Yeah, so if you could just go back to the previous slide, that would be great. So again, this really talks about the importance of, when I talk about Indigenous sovereignty and the inclusion of Indigenous health leaders, this is why. But at this time, even a decade ago, all of that was entrenched in university, hospital-based, education-based, government-based research. The need for, you know, as Indigenous people say, nothing about us without us, which I know also patients have used that term as well, right? Nothing about us without us. So next slide. And this slide is taken from a pamphlet that was given to schools. There were 4 schools. And I just want to draw your attention to what was promised. And so this is one of the things that is very problematic about any study, is what does it promise our people? Because our people want to know that there's tangible outcomes for them. In this case, there's this crazy idea that by doing this brainwave training, it was looking at your brain waves, and that you would be able to change your brain waves. You would be able to change your thinking. And by going through this training, it said that it was increase creativity by 50%, increase your IQ by 11.7 points, reverse brain aging, more happiness and joy and less fear and anxiety, more patience and understanding of self and other, peak performance in sports and intellect and beneficial long-term personal changes, and that it worked with really vulnerable families in Prince Albert that were involved in community schools. And so this was the brainchild, so to speak, of this biocybernaut. And I'll leave you to look at online. You can do more and you really should look at this if you want to understand about building trust with Indigenous communities, and the fact that this just came out in terms of what happened and how Indigenous people might be feeling right now. But you can see the expectations that are raised and the targeting of vulnerable people, vulnerable families. Next slide, please. And so there was a researcher involved from First Nations University. And as you may know, this is another piece that I was involved with quite a bit. This was Carrie Barassa. She turned out to be a pretendian, but she did rise to be the top Indigenous scientist in Canada at one point in time, as being the lead of the Scientific Institute, or the Indigenous Institute for the Canadian Institutes of Health Research. So we're not talking that this is a little by the side type of crazy project that no one important was involved in. And what happened was they recruited through the school, and it was the children who were getting the pamphlets. And if you look at the report, this young girl goes home and she convinces her mother to do this. And so Jeff Leo interviews this family who travel, all expenses paid, to Victoria, thinking they're going to something that is going to give them all of this benefit, but also might be a really pleasant experience. They get there, they're put in dark rooms, they have electrodes put to their heads. They're not told really anything much about what's going on. They find it weird and creepy and very disturbing. But again, being people who got this free trip, they're really afraid to say anything, that they're uncomfortable. And when you look at trauma in the trauma related to the things that happen to Indigenous people, putting somebody in a room alone with electrodes on their head and listening to weird trumpet music is just really really awful, and it can be very triggering. And one person did have a panic attack, and there were, I believe, around 30 individuals and children and their parents that went through this training. So quite a few people. There was collection of blood and urine samples, and so you could go to the next study or the next slide. So really, luckily, the Minister of Education in Saskatchewan shut it down. But there's still some accountability around this. And this is where I think, in terms of us doing research with patients, Indigenous patients and families, that we need to ask what went wrong in this case, because I can tell you that groups of Indigenous people who may benefit from participating in research that is related to organ donation and transplantation, many of them will be people who are vulnerable in a number of different ways, including people not understanding what it means to live with intergenerational trauma and what the triggers are that are associated with that, even when you go into a context where there are power dynamics and different things happening to you medically, with people wanting to touch you, people wanting to ask you invasive questions, with people wanting to take blood and urine samples. And there's all kinds of history around why Indigenous people this may be triggering, and why we need at the universities levels and government level and hospital level need to protect people and need to understand that there may be more things going on than we understand. And that these things people won't talk about. They won't tell us if they're uncomfortable. And so in this case, again, we have people who went through this that were very, very uncomfortable, but were afraid to say anything. So what went wrong? When I looked at the documentation, clearly the ethics, so research ethics, and you had an ethics board that did not have, as I could see, any Indigenous people on the ethics board. You had a shady researcher for sure. There was something up about this person. First Nations University was her employer. They knew nothing about this research. That's been shown. So the University of Regina gets this application with an Indigenous researcher. And I read through it, and there was no protocol. So the things that you would expect in an ethics application simply weren't there. So protocols, how patients and families were going to be supported, how to make sure that if something went wrong, that there was lots of support for them. And so the question now, and as I talked to the reporter, the question is, he asked me, is how do we make sure this doesn't happen again? And so the reason I raise it in this context is simply to let you know that this is still happening, and it can so easily happen. And so this is why we need to adhere to those sovereignty principles. And I won't go into any more details. You can ask me more details if you want about the study, but for our purposes here, there's enough online that you can look at, but you can see that things went really wrong for patients and families in this context. Next slide, please. So original research ideas, I've talked about this last year somewhat. I'm going to talk about it again, because yesterday it seemed like there was quite a bit of concern about how do we engage Indigenous patients and families? How do we go about creating research projects? So original research ideas can be generated by First Nations, Métis groups, or they can originate by the researcher. You can generate an idea and you can go to Indigenous rights holders, and you can ask them if they want to participate in a study. People, and I'll talk about this more about where sovereignty lies, but the rights holders that I'm talking about are Indigenous health leaders, as well as persons with lived experience, elders, and knowledge keepers. And what's important is the nature of that partnership. and looking at those research guidelines and understanding sovereignty, doing your homework before you just burst in and say, you know, I've got this great idea that I want you to participate in. Next slide, please. And so the development of any partnership needs to be grounded in ethical principles adopted by Indigenous groups, but we also have hospital and research ethics boards. And in the case of the University of Regina, I have no idea how I know any of the researchers that I know would not have passed that study. So I'm not exactly sure what was going on, but the really, really scary thing in this context is that the person who was Indigenous wasn't Indigenous. But even if they were Indigenous, the fact that, you know, this question that Dr. Amanda LaValle raises in the CBC report is, was it just pushed through because it was Indigenous and because the researcher said the community wanted this research, right? And in this case, the community relates to kind of what you call the community. So it was a number of patients. Or I should say, it was parents, students were named as the community. So some Indigenous people had gone through this training, teachers who work, who are Indigenous. So all of these people are Indigenous. And there were some clinicians, but there was a small group of Indigenous people who felt that this research should go forward as well. So this is really interesting in terms of what this is. And one of the things that I'll tell you just as a footnote to this is some of what's happening in the PA study is that our society is incredibly uncomfortable with Indigenous people. Intergenerational trauma, the impacts of colonization make us incredibly uncomfortable. So what do we want? We want a quick fix. Everybody wants a quick fix. Everybody wants an explanation of why these families, in this case, who are attending the school, why they're not doing better. So you saw the list of what was offered, and that's basically our society would love nothing more than to send Indigenous people to a 7-day training, change their brain waves, and wipe out all the impacts of colonization. But those of us who grew up in it, those of us who live it every day, those of us who watch our people struggle, know that this is a marathon, a long, long marathon, an ultra marathon, and it is not a quick fix. And so even when you go to engage with Indigenous people in research, you have to be ready for a marathon. You are not going to just engage them quickly, have them participate, wrap it up, and say that's that. So, and so I'll move on to the next slide as well. So when creating partnerships between Indigenous communities and institutional stakeholders, it must be recognized that every person comes to the partnership with needs and expectations. So as researchers, as patients who are non-Indigenous and family members that work in this area, you have expectations too, and that's okay because it is a partnership. So it's not just a one-way thing. But in most contexts, there are power imbalances that exist. And so this is why the data principles are really, really important. And certain First Nations groups, in the case of the Prince Albert study, highly disadvantaged families that are living in contexts. So you need to watch the report because the mother comes home and she said, we thought this was going to be life transformational and that we were going to come back and things were going to be different. And we came back and things were really still crappy. And at the end of it, I think we're worse off than before we went to this because we came back and nothing had changed. And so you have to remember when you engage Indigenous people, particularly people living in circumstances that are really crappy, but beyond their control, housing insecurity, food insecurity, the tyranny of geography, it's all of these things that can happen that make it hard for them to participate in research or participate in the clinical work that they need to. You have to understand that all of this is going on and there is a certain level of vulnerability, and that's why it's a marathon. And that's why you need Indigenous health leaders to be involved in this. You cannot just have patients. You cannot just have families. You need to have Indigenous leaders involved. Next slide, please. And so these questions are important in your research. How will the data be collected? How will patients and families be informed about the need to collect health data? There was lack of information in the PA study, and this is not necessarily uncommon. Who will have access to patient data prior to it being aggregated? Nobody knows where the data went from that study. That's a question that nobody seems to know right now. Who will have access to the data once it's aggregated? Who will analyze the data? And what are the process of deciding the focus of the analysis? How is sovereignty over this process ensured? And can we go to the next slide, please? So where does sovereignty lie in the context of doing research with patients and families? So from an Indigenous perspective, and sometimes our Indigenous leadership will get this wrong, people who don't work in the area of Indigenous research. So the best person to ask is a researcher who's Indigenous, if you want to know, to tell you the truth. And so I love our leadership, but sometimes, they'll just say what pops into their head about something they don't know about, just like every other political leader. So let me tell you where sovereignty lies. In the context of doing research with say youth who are experiencing rare disease, I think was one of the talks yesterday, is that sovereignty lies with that person, that patient, and their caregiver, their guardian. So that's where sovereignty lies. If they choose to participate in a study with you, and they are Indigenous, then sovereignty lies with them. They have a choice to do it or not do it. That's up to them. So you can have Indigenous patients in your study without having Indigenous leadership as part of your study. But as soon as you move that to an analysis of Indigenous patients, and I would say never have Indigenous patients have distinctive based First Nations, Métis, Inuit cohorts, right? So distinction is really important. But sovereignty then also lies first at the community level. If you're working with the community, say a reserve, then it moves up to regional, and then it moves up to provincial and on to national. So sovereignty begins with the patient and begins with, in this case, the guardian for the children. But as soon as you start to do your analysis that's based on the identity First Nations, Métis, or Inuit, you need then to have a partner. So this raises the next question. What's the capacity of our Indigenous political bodies such as the AFN, Métis Nation, Métis National Council, and the Inuit ITK? What about the regional level, and what about the community level? And I can tell you they're stretched to the max when it comes to research right now. There's so many things going on, and it doesn't have to be political bodies. It can be a friendship center. It can be an Indigenous women's group, for instance. So there's a number of people, organizations in that you can partner with, but you have to come with resources. And when I say resources, not just financial, with human resources. And I'm hoping, with the Indigenous platform, that's one of the things that we can get enough funding going that we can provide and have people who are Indigenous that can help with Indigenous focused research, right? So I can do a bit of that, but a little bit stretched to the max. So you are challenged as academics to work with Indigenous populations, but that doesn't mean that we shouldn't try. And it doesn't mean that we shouldn't look at involving people in randomized controlled trials who are Indigenous and looking at Indigenous specific types of clinical and community-based research. So that kind of wraps up what I want to say today. I think I'm almost on time. And I hope that gives you something to think about. And I encourage you to go to Jeff Leo's story and take a look at it, because it is, as Dr. LaValle said, it's bonkers and whacked. And so when a researcher says something's bonker and whacked, it's not scientific. It's not based on evidence. Thank you.
Thank you so much, Dr. Tait, for the presentation. I think it's a really important one, and for presenting the Prince Albert study as well, which was so recent, only like 10 years ago. I'll pull up the CBC news article that you referenced and just put it in the chat in case other folks are interested in reading more about it. I will also invite folks to put in your questions into the chat or send them anonymously to the CDTRP, or you can raise your hand and ask them live as well. But we do have a few to start with. So maybe I'll start with Len's question. Can we assume that what happened with the cybernauts study could never happen again, or is there the potential that something similar could slip through the cracks again?
That's a great question. And that's the question that, Jeff Leo had asked me about, could this happen again? Because it is shocking. And there are some really unique circumstances. But one of the things I think that it raises the issue about the relationship that Indigenous people and patients patients and families have to for-profit companies that want to do research. And so in terms of this, one of the red flags, of course, is these were for-profit companies. And there was a lot of confusion. So one of the things that I take away from all of what I reviewed is that, I said to the reporter, this seems to be an example of a whole bunch of busy people. And everybody involved were really, really busy. The Research Ethics Board, the University of Regina, they were busy. The researcher, she was also busy. We don't know exactly how much she pushed in this. We don't know how much money she got paid for this. There was $6 million floating around. So the vetting of this, we in universities and hospitals and that we're working with less and less resources all the time. And of course, in terms of Indigenous faculty and community people, there's enormous amount of pressure on us to participate all over the place. And you're stretched to the max. And so some of what happened was that the Indigenous leadership did not know about this. So in Prince Albert, which is a city of 35,000, Prince Albert Grand Council should have been talked to. The researcher knew this. So this really falls at the feet of the researcher who was basically going around all of the Indigenous leadership, Métis Region 2. And instead what she was doing is she was using this language of community. Oh, the community asked us to do this. So what she meant was the community of the few teachers, parents, and students that had been through this training already that were Indigenous. And it wasn't, and there was slippage with the school board. And, again, really, really busy. I'm really quite impressed by the Minister of Education who shut the study down and asked some really serious questions. That is heartening, but yes, it could happen very, very easily again, because at any given time, you have a lot that's happening. And if there's anything I've learned, and not to be critical of universities, but when there's $6 million hanging in the air, I can tell you that the desire to maybe, let something like this slide through. I mean, we hope that doesn't happen. But I would put that at the feet of the University of Regina. But has this happened in other contexts? Historically, yes, in terms of blood and tissue and other things, lack of protocol. So what's really sad about this situation, though, is that this just will, like, I've got a stem cell planning grant with a colleague of mine. It's their technology, it's their work, it's their lab, and we're doing some focus group in Prince Albert, of all places. So this is going to make this incredibly hard, because people are going to be angry, and they're going to be angry at all of us. And so that's what I'm saying, is that expect people to be angry. So I always say to my students, we will go 3 times and we will get yelled at for 2 of those times, and we're going to have to carry the burden of these big mistakes. But on the 3rd time, our people are generous and wonderful and kind, and they want to be involved in research. They will start to talk to us about the research project and what we need to do. So it's a marathon, and you need to expect to get yelled at. You need to expect anger directed because of these past things that have happened in research and elsewhere.
Yeah, thank you. That makes me also think, kind of going forward with research as you're in that same region, that, there's almost a need for some kind of trauma-informed research now, right? That's also Indigenous focused, but also trauma-informed from these past experiences. We have another question from the CDTRP, and so they say they thank you for the excellent presentation and highlighting the ongoing power imbalances and equity issues in Indigenous health research. And a congratulations on having passed the resolution this month. They're wondering if you can share a bit more how you've engaged with the BC First Nations chiefs to get this resolution passed.
So it's funny as a researcher, because you only hope that things will go well. So we applied, and I thank CDTRP for this in so many ways for supporting this, and Craig Settee, who was involved as our moderator. So I had heard about Chief Philip and that he was a double transplant recipient, and I kind of stalked him a little bit, and then I ran into him in the Saskatoon airport. And I heard his voice, and I had recognized his voice from a news report or something. He has a distinctive voice. And so I went up to him and had a very awkward conversation with him. But that's how I first met him in person. And then, you know, they're busy. Like, I can't even tell you how busy they are. So I started working with questions around the David Dennis case. And then, you know, Chief Philip, we applied for the Cafe Scientific. Chief Philip was involved in it. He came and gave a presentation, but one of the really cool things is he stuck around for all of the Cafe Scientific. And then at that Cafe Scientific, for those of you who were there, if you remember, we decided that we would put forward a resolution for the June meeting with the chiefs. So what I did is I went online, and again, anyone can do this. You know, I went online, I took resolutions that they had passed already, and I made one based upon their format, and sent it back to the BC chiefs and waited. And then all of a sudden I received back a revised resolution, and it's on the agenda. And that's how easy it was. That's how it went. The funny thing is, as I watched this week with them reading the therefores and what they need to do, and that resolution I hope to share with everybody as soon as it's up on their website, because it is theirs, it's not mine. And it was really wordy. I was like, God, an academic writes this, and it's just, and the guy was laughing. He goes, this is like, I can hardly say all the words. And so it was very embarrassing for me, because it's typically of what we tend to do, is make sure all the I's are dotted and the T's crossed, but it did pass. So now they will move this towards the AFN, which I've kind of given a heads up that it's coming. And I don't know what the process will be, how that will look, because the BC Chiefs does not control the AFN. So it will really depend on what's happening. But I think we can push forward other resolutions now that this has been done with other provincial First Nations, Métis, and Inuit organizations, that this can be, I think, a real cornerstone for moving forward.
Really exciting. Yeah, I look forward to kind of having the updates and reading through it myself. Yeah. We do have okay, I'm mindful of time. Maybe we'll do one more question. Maybe I see, Ruth, you have another question in the chat. But Viviana asks, before transplantation, is any assessment performed to identify the risk of non-adherence after transplantation? This result can be a reason to select a patient to get a transplant. And with this, are there any interventions from the transplant center together with mental health professionals to intervene in this risk of non-adherence after transplantation?
So I'm not sure that if that's specifically, but I'll just say for Indigenous patients, as I said, you know, we really need to understand in terms of equity, and this is what this is the paper that this was the project or the talk I was going to give, and I didn't. And to me, this raises the question of where is bioethics in the discussion of Indigenous people. So most of what happens to patients in terms of non-adherence would be things that influence, that have nothing to do with clinics, nothing to do with hospitals, but everything to do with your life outside of all of that context, your life at home. And so most of what happens to patients, we don't talk about, we tend to call them patients instead of lived experience. We tend to talk about the clinic experience, but most of what happens in other contexts of which people are living their everyday lives as they're living through the illness that they have, or post-transplantation. So for Indigenous people, there's all kinds of things that can mean that are out of control of people, that they cannot maybe get to appointments and there needs to be consideration for those. So rather than it seen as something that they're not complying, they're not adhering to what they need to adhere to, we need to better understand what's happening and better support. And so there could be a number of different interventions, including remote presence technology that helps with the geography piece. There could be other kinds of financial supports in that. So I'm not sure that answers the question, but I think bioethics has a role to play. I think it's way too narrowly focused on what it is. And I think, looking at the work of Paul Farmer and others, we need to push out this idea of what bioethics encompasses.
Thank you so much, Dr. Tait. That was a really great way to kind of tie in all of the themes from your presentation today. So I want to thank you again for your presentation. I won't be able to take any more questions. There are a few more in the chat, but maybe those can be circled back to at a later point. But we're going to move on to the next presentation now. And